Again, not too much from me here, guys, but I'll just hand you over to Stephanie, who's part of our anatomic pathology team. And she's going to run you through a little guide to histology and sample submission and sort of do's and don'ts around that. Similar to before, we'll leave some time for questions at the end. But if there's anything that comes up during the course of the thing, put it in the chat, and then I'll go through that with Stephanie at the end of the presentation. So I'll hand you over. All yours, Stephanie.
Brilliant. Thank you very much, David. Hello, everyone, and I hope you had a good break, and also I hope you had already a very good session in the morning. As David said, I am part of the anatomic pathology team at IDEX. I've been working for IDEX quite some time. I've been a pathologist for many years now. I'm originally from Germany, so a bit of the German accent still remains, I'm afraid. And I would like to give you a quick overview over histology sample submission. We obviously get a lot of histology samples, so I try to cover as much as possible within an hour. There will be some topics that I won't be able to cover completely, but obviously you're very welcome to put any questions in the chat, and will be doing my best to answer them. My general agenda for today is that I want to talk a bit about general sample submission first of all, and then I'm going to talk about specific examples that we see regularly. And if we have time, I'm going to quickly touch on ancillary tests as well, but that's a bit of an add-on because that's done at our side and is a bit of a separate topic as well. So I really want to focus on the sample submission. So as a general consideration here is obviously that we are working together. So I always see us as a pathologist, either clinical or anatomic pathologist, as a team with everyone of you, so every clinical veterinarian. So we're really trying to work together here to get the best outcome for the patients, obviously. And the one thing that I would like to say is that whether you get a good and really helpful result, obviously it depends on us, but it also depends on the sample quality and the information that you provide. So it's always a good starting point to have really good clinical information as well. And one of the things that is really important is to pretty clearly identify the tissue samples that you are submitting to allow for adequate fixation, and really to give us all the appropriate history and possible the adjunctive information that you might have, thinking about previous treatment, response to treatment, radiographs, etc. And just something to bear in mind, as I said, if we have time, we might quickly go through that, but also to obviously set the client's expectations right. There is a possibility that we will need additional tests and that the report is not going to end with our histology result. So as a general rule, we have different samples that we look at from day to day, endoscopic biopsies, true cut biopsies, for example, in the kidney or in the liver, and then incisional and excisional biopsies. And for us, it's really important to know what the method was. So true cut biopsies is something that is easy to identify histologically, and endoscopic biopsies usually as well. But especially when you're removing a mass, it's very important for us to know if it's an incisional sample or if you want us to look at the margins, because obviously we wouldn't do that in an incisional biopsy. Some sites are easier to biopsy than others. For example, if you have a small skin mass, as shown in this picture, for example, this is so small that it can be probably completely removed just with a punch. And obviously large skin masses, or we're going to come to whole organs, for example, as well. These masses are harder to excise, more difficult to excise, for example, masses on the distal limb. And one thing to keep in mind as well is that visceral masses, for example, masses in the spleen or masses in the liver, are often not clinically detected until they are larger and they compress the surrounding tissue, or they have some degree of hemorrhage, or getting clinically apparent. And you know this better than I do. Obviously, you need some specialist equipment for some of these biopsies, for example, an endoscope. As I said, single small lesions are simple to sample. If you have larger lesions that cannot be completely excised, or for some cases where you want to have a diagnosis first before you plan the further surgery, then it might be helpful to have multiple samples from all areas. So imagine you have a large skin mass, then it's really helpful to have a few samples for histology. For example, if there are some necrotic areas, that would be helpful to avoid them, and just give us a bit of an overview of what the sample looks in, what the mass looks in different areas. Really important for example, for skin lesions, you can have multiple or disseminated lesions. So the pathologist always says the more the better for us. Obviously, that's not always so easy and not always possible clinically. But if we see, for example, you have several skin masses, if we see biopsies or samples of quite a few of them, then we can make this a bit of a rounder interpretation. And just something to keep in mind that obviously a patient may have more than one disease processes as well. As I mentioned already very quickly, if you can, it's very advisable to avoid any areas of necrosis, secondary infection and ulceration, because that will obviously pretty much affect what we see on histology. Generally, as I said, the pathologist always likes to have a lot of tissues, so larger samples are more likely to be representative and therefore diagnostic. That's the general rule. Again, it's not always possible to submit really larger samples. Just something to bear in mind that smaller samples are also more prone to collection artifacts, for example, crushing or smearing of nuclei histologically. Again, if you can't excise the whole mass or if you can't submit the whole mass for whatever reason, it's really helpful to include the margin. First of all, if you want to have an idea of what the margins look like, and obviously we need to be able to look at the margin, but also it can help us determine a benign or make a decision between a benign and a malignant lesion, because we're looking at the way the tumor behaves towards the tissue border. I know that electrocautery and lasers is very, very useful to stop bleeding. The pathology team don't really like any electrocautery because it causes a lot of artifact in the tissue, which I'm going to show you in a second. And on the same note, try and handle the tissue, at least until it's in formalin, as gently as you can, and that will avoid any additional artifacts. We often get lymph node biopsies, and usually we can at least say something about lymph node biopsies, but if you can, it's better to have the whole lymph node, because that helps us to assess the whole architecture of the lymph node. So I have an example here of a really good quality sample. That was a skin mass. It's a sebaceous hyperplasia, which is a bit inflamed. I can see the sebaceous glands, which are all of these glands here. You might recognize them. And there's a bit of inflammation here, a bit of fibrosis, and the epithelium shows a bit of hyperplasia. So perfect sample, perfect slide. And I'm showing you this because I want to give you the other the other example as well. This is a sample that wasn't sufficiently fixed. So it's basically, I think, the same lesion. So you see the same cells that you saw before, but the architecture is very much disrupted and the cellular detail is really hard to appreciate. And then we have a sample here that has been squashed and shows some quite severe crush artifacts. Again, some sebaceous glands, I can see them, some hair follicles as well. And then there is some sort of infiltrate, which is probably inflammatory, but it's really hard for me to say that. And on that note, I've already touched on fixation and processing. Processing is done at our, obviously at our place, so that's not something that you have to be really concerned about. But fixation is really important to allow for a good pathology report as well. And we get quite a few questions about this, so this is why I think it's really important to quickly discuss this as well. Generally speaking, it's advisable to submit the samples in neutral buffered formalin, 10%. And something to keep in mind, especially when you have large samples, is that the tissue penetration is approximately 1 centimeter in 24 hours. So it's really slow if you think about it. And that means the larger samples that you submit to us may be delayed. So the report may be delayed because we might need to have additional fixation in the lab before we can process them. And it's advisable to have a ratio of at least 10:1 formalin to tissue, which means that if you have a small biopsy, that's really easy. It becomes a bit more complicated if you have a large sample. And there are, and we are aware of that, there are samples that for several reasons might be really difficult to complete as a whole, which can be a spleen or a whole leg. And something that I will come back to as well is there is always a pathologist on duty that you can call and you can talk to us and ask us questions. There's always someone who can help you. It's not so uncommon to get these questions where, you know, we get a call and we are told, I've just removed a large leg from a greyhound and I don't have enough, I don't have a box that's enough, I don't have enough formalin, what to do. So there are ways we can help you with that. And Another thing you can do is, for example, for the spleen or legs or whole samples, large samples, you can fix them in formalin and then wrap them in a formalin soaked gauze and put them in transit like that. And we can support you with large submission bags as well. There is a rule, especially for spleens. There was a recent publication a couple of years ago, make a statistical assessment of how many samples do we need to be able to exclude hemangiosarcoma with confidence histologically. And this publication said at least 5 to 6 sections. So if you can't submit the whole spleen for whatever reason, then my advice would be not to just submit one single sample, because we might miss the hemangiosarcoma, for example. We might just see necrosis, or maybe the dog also has a lymphoid hyperplasia, and we might miss the more sinister findings. So if you can't submit the whole spleen, most important for the spleen, then it's really advisable to submit a few sections. And also important for the spleen and some larger skin masses, for example, I just had a case this week, actually. It was a large mass from the prepuce area. And obviously in that area, scrotum, prepuce, the skin is really thick. So in these cases, it can actually help to just slice into the section. Don't slice through it, but just slice into it. And that will allow for a better fixation. And spleen, testicles, this is all the same because they have large or thick fibrosis surrounding it. They have a tunic, so it can really help to slice into these. If you slice through it, if you want to, or by mistake, then it's just really important to orientate the samples so that we can assess the margin. For example, you can say, I've put a suture where I've cut through the sample, for example. There's one exception to the rule, which are eyeballs. So if you enucleate an eyeball, my advice would be not to cut into the eyeball, because that makes the assessment really, really difficult in terms of whether there's length luxation, for example, masses, orientation of the eyeball, etc. So that's the big exception to cutting into masses or into samples. One thing to remember is that you can keep samples in the practice as long as they are in formalin, even if you don't want to send them immediately, because the client is still thinking if they want histology or any other tests. So you can keep them in formalin, and they're pretty safe in formalin for a long time as well. I'm going to give you an example very quickly as well in a second about clearly labeled and separate pots. So that's obviously very important. One thing to remember is that there is considerable shrinkage that can occur in formalin. So if you have two masses, for example, that are roughly the same size, and you submit them as one is larger and one is smaller, that might not be so easy to distinguish at our end, because in formalin it can shrink quite a bit. Generally saying never freeze a sample for histology, because it can create quite a similar artifact that you've seen before. If the sample was frozen by mistake or for whatever reason, or not adequately fixed, then it's really important to tell us this on the submission form as well. We are obviously providing containers, so this is the best that you can use. It's not advisable to use any glass containers or any Tupperware or anything else. So the containers that or the pots that we provide, they have a good lid, they close properly, and they don't leak. So this is what I would always recommend. And as seen in this picture here, you can use cassettes if you have a very small sample, for example, endoscopic biopsies or a very small skin biopsy or very small mass, or sometimes, for example, endoscopic biopsies of the nasal cavity, for example. The only thing to be careful with these is to avoid any crushing, so not to press the cassette down on the sample. Yeah, I've already touched that. We need labeled and appropriate containers. And if you submit multiple samples from the same patient, then it is important to label each pot with the name and the site where you've taken the sample from as well. It's really helpful if the labeling on the pot matches with that on the submission form. It's quite common that on the submission form it says left leg, and then on the pot it says right leg, which is all right if it's just one sample, then I just say leg in my report. But if it's obviously more than one sample, then that becomes a bit more important. Yeah, I've mentioned the containers already. Another thing that we have a problem with is if you have very narrow containers with a very narrow neck, and the sample is kind of squeezed through the neck and is then in the container, that's really difficult to get out. And also the sample then basically gets the shape of the pot that you have submitted it in. Yes, I've already said about the margins and the orientation of the sample. And if you want to submit separate portions, then it's also very helpful to have them in separate and labeled pots. If you want to ink or if you want to mark the samples for whatever reason, for example, you want to mark the dorsal, the ventral, the cranial, and the caudal margins, then it's really helpful to use sutures. I always say ink, but I know that in practice, ink is not very common. So you might not have, or you might maybe have one ink, but not different colors. So I think sutures, long sutures, short sutures, no sutures, as long as you tell us on the submission form what you've done, are also really, really helpful. And this is just a good example of a sample submission that was really well done, well labeled. So the client said, this patient has two masses. One is a mass on the dorsal aspect of the thorax. They've also mentioned that an FNA had been taken before, which also is really helpful for us to know. And then here on this pot, they said, obviously I've blurred out the name, but they said shoulder mass. So we could clearly identify these two. Although again, he said dorsal aspect of the thorax and then shoulder, but that's close enough. And the second mass he also described as a cystic type of lesion and labeled the pot with tail mass. So that's really helpful and easy to identify. I'm just going to give you a very quick overview of what is happening in the lab so that just that you have an idea. So the first thing that happens when we after we've sampled the sections in the lab or sampled the sample in the lab is the tissue processing, which goes through several steps, dehydration, clearing, and embedding. And that generates the paraffin block, which you probably have seen before. And then this paraffin block gets sectioned on microtomy and reveals an unstained slide. And then we always have a routine section, or routine stain, which is hematoxylin and eosin. And on the same block, we can then request special stains if applicable as well. And as I mentioned in the beginning, we really depend on the information that you provide. And that is more or less more important in some cases than in other cases. For example, if we just have one skin mass, it might not be so important. If it's a liver biopsy, it's completely different, and the clinical information is very important indeed. And we always try to correlate our histological findings with the clinical history and any other results that you've submitted previously, any treatment, anything. In most of these cases, there are obviously cases where we can't be 100% definitive, for example, because it's a very pleomorphic, very poorly differentiated tumor. And in these cases, we will suggest additional tests. This could be on our side, so it could be immunohistochemistry, for example, or it could be on your side. And we say it's really helpful to correlate these findings with diagnostic imaging, for example. We do have, as you know, we have a really lovely team of other experts that work really, really closely with us in internal medicine, oncology, and dermatology. So as I mentioned earlier, I've been a pathologist for 17 years now, coming up to 17 years. So I'm not the best person to give you any advice on oncology treatment or any other treatment. So luckily, we have the internal medicine oncology team, for example, to help you with that. And this advice, this consult is free of charge as well. We rely a bit on you interpreting the histological samples, histological findings in the broader clinical context, of course. If you just submit one little biopsy of the liver, for example, it's really hard to say, is it a mass or is it a liver biopsy? Just something to keep in mind. And I'm going to mention this probably a couple of times. I said before already, we're really grateful for any feedback. You can always reach us. So all of our reports have the direct phone line at the bottom. They also have a direct email address. You can email us if you can't find time to call us during the day. And for example, if I'm on holiday, there will always be a colleague who is in charge for answering the phones and discussing the cases with you as well. And for us, obviously, we don't see the patients, so it's really, really nice to have a follow-up as well, especially if it's a challenging case or an unusual case, but really in general. Okay, so I would like to talk a bit about the more challenging samples or more challenging surgical approaches maybe that we see from time to time. And we get a lot of questions about skin biopsies, especially how many skin biopsies, which sizes, and so on. So that will be a bigger topic of today's presentation. Skin biopsies are one of the cases where we really rely on a lot of clinical information. So basically, whatever you can put down on the submission form is much appreciated. That means information about the animal, so that includes the breed as well. Often we say, we see on the submission form crossbreed, which I know you can't always tell, but if you can tell a crossbreed of what, that might also be helpful. Also the age, because just certain skin conditions are not as common in younger patients than they are in older patients, for example, if you think of, for example, cutaneous lymphoma. And also the neuter status, because that helps us ruling out or ruling in certain endocrine disorders as well. And as I mentioned before, if you have done any treatment or if we have any previous culture, any response to treatment, that's also really helpful for us to know. And the distribution and type of lesions, your clinical description of a skin lesion is also really, really helpful. We get the question quite often of, if you have a patient that is on steroids, how long does the patient need to be off steroids for us to, be able to interpret the histology sample? And the general rule is 2 to 3 weeks. But obviously that depends a bit on the severity as well. So if the dog or the cat or the patient can't really be off steroids for longer, then by all means take the biopsies earlier than that if it's not possible from a clinical perspective. It's just really helpful to know that there has been steroid treatment. And generally speaking, for most skin conditions, if you can sample the interface area with the normal skin, that could be really helpful. And a bit similar to what I said to the spleen earlier, the more we can look at, the better. So if you 6 samples, especially if there is a multifocal disease, that is also really helpful. I've put an example here of a pemphigus case, which is quite regular that we see these cases. And this example here should illustrate that it's really not advisable to scrub or clean the skin before you take the biopsies, because if we want to look at this pustule here, which is one of the main important things we look at when we want to diagnose pemphigus, if you rub this off, then obviously all of this pustular area here will be gone, and that really affects the ability to make a diagnosis of pemphigus in this case. And I always say, once you are taking biopsy for histology anyway, unless you're really sure what it is already and you just want a confirmation, I always think it's really helpful to have 1 or 2 samples in saline as well and just save them for culture. You can potentially submit them together with the histology samples as well and just say on the submission form that you want to put them on hold and wait for the histology report first and then decide if you want to process them. But for me, it really makes sense once you are taking biopsies for histology, just to take biopsies for fungal culture and bacterial culture at the same time, just in case. I don't really think I have to mention that we obviously need a sharp and new punch for each patient. So that's, goes without saying, I think. Again, pathologists like a large sample. So we say 6 to 8 millimeters biopsy diameter are best. But obviously that's not always possible. So you have these areas here, for example, that are a bit more difficult to sample. So then obviously 4 to 6 millimeters biopsies, smaller biopsies are also fine. And if you can put, like in this case, if you can put the whole lesion in one biopsy, then it's really helpful to have the lesion at the center of the punch, ideally with a bit of surrounding tissue as well. And as I said before, if that's not possible, then if you include mostly the lesion, but you also sample a bit of the periphery, that's also really helpful. Don't share or distort the tissue with going one way and then the other way. Just rotate the punch one way only. That helps with any avoidance of any artifacts as well. And as really with every sample, if you want to submit for histology, the sooner you fix them in formalin, the better, because that preserves obviously the cells, but also preserves the architecture. Yeah, as I said before, and you can also consider fresh samples for culture at the same time. We have this very specific case, very complicated cases sometimes of alopecia, which the challenge there is actually to capture enough of the affected hair follicles. So the problem is that depending on the area, some of the histological sections don't have many follicles anyway, and then out of these, not all of them might be affected at the same with the same severity, really. And in these cases, it's really important to biopsy the center of the lesions, take many samples, multiple samples, and use large punches as well. And if it's possible and you can identify a recently spreading area, then it's really helpful to sample this as well. But with a recent alopecia area, it's helpful not to include the adjacent normal skin, because that makes it a bit more complicated for us to see, okay, there are some normal hair follicles. Are they just because not all of the hair follicles are affected, or is it because they are at the periphery of the biopsy, if that makes sense? If you have a very unusual case or a subtle case with only tiny pieces of tiny areas of alopecia, then it's also helpful to take one normal sample as a control sample, especially if you have certain breeds like Pomeranians, for example. They have really unusual hair follicles histologically, so it really helps to have a normal sample, but that would be a sample that I would ask you to submit separately so that we don't get confused with the other samples. And yeah, I've already mentioned Pomeranians as an example. So for skin conditions in general, and especially for alopecic skin conditions, it's really helpful to know the breed. And I think that with alopecic lesions, if I'm completely honest, this is often a teamwork between clinicians and pathology, I think, because we'll often give you a list of differentials, but for example, Cushing's disease, for example, and other endocrine disorders or cyclical flank alopecia can look completely similar on histology. So that often really needs clinical correlation. Yeah, I've already quickly mentioned crusts when I spoke about pemphigus. Just to bear in mind that most crusts are actually secondary. So pemphigus is an exception to that, but most crusts are secondary and are caused by secondary bacterial or fungal infection. So if you have a suspicion that this could be the case and it's not a primary crusty or primary lifting lesion on the skin, then it might be worthwhile to wait for a primary lesion to develop if the patient is stable, and then to sample these primary lesions, because then we will get rid of all the secondary bacterial changes that might get in the way of a histology interpretation. If you have a crust, if the crust falls off, I've already mentioned no scrubbing and no cleaning. And if the crust falls off, you can just put it in formalin together with the samples. We will look at it and we will consider it as well. And it doesn't increase the price as well. And yeah, it might be helpful to look at secondary pyoderma treatment. If you think there is secondary pyoderma, it might sometimes be beneficial to treat that pyoderma before you submit a biopsy for the reasons I've mentioned. Erosions and ulcerations are an interesting topic, because they are often just a reflection of something that's deeper, something that is going on deeper in the tissue. And for these, again, it's really helpful to have the epidermal margin of the active lesion. For example, in this example here, you have this quite big ulceration, or here as well. So I would really like to see a biopsy that includes the margin of this and the intact skin surrounding it. With the ulcerations and erosions, it's really helpful to have deep biopsies as well, because they are not so rarely caused by an underlying vasculopathy, which we won't be able to see if we have a very superficial sample. So generally speaking, if possible, depending on the location, deep wedge biopsies in these cases may be better than punch biopsies. And the really shallow biopsies, especially if they are only in the periphery, they might not be that helpful, because obviously the body reacts to these lesions with coagulation tissue, and then that's what we see histologically. And especially, generally, really, but especially with erosions and ulcerations, it's really important to avoid secondary lesions as well. And now we have this slightly, it doesn't really fit into skin biopsies often, because it's more of a mass, but it's a bit of an in-between case, really. And these are the cases of draining tracts and sinuses, for example. A cystic lesion on the dorsal head of a young puppy is probably a dermoid cyst. And obviously, if you biopsy that just with a very small biopsy, then it's really hard to make that, to come to that conclusion that it's a dermoid cyst. So in these cases, a large wedge biopsy that includes the whole tract is really helpful here. So this is an example of a dermoid cyst. And you can, it's very, for me as a pathologist, it's very easy to say, oh yeah, that's a cyst, there's nothing to worry about. It's local, it's secondarily ulcerated, I can see the architecture. Obviously, if you only have a biopsy that includes this, then it might not be as obvious for us. And it's really important to see the content of these cystic areas or of the tracts as well. Is it pus or is it keratin, foreign material, bacteria, something like that. So this is another example where you can see skeletal muscle. This was a really deep sample, muscle sample, muscle biopsy, deep muscle biopsy with a foreign body here right in the middle. So obviously, if you just biopsy here, this area, then you wouldn't be able to identify the culprit in these cases. And then we have macules and patches. Again, if you can sample recent lesions, so that's one of the take-home messages here. If you can sample recent lesions that are not affected by any secondary changes, that's really helpful. And even more so, especially with patches and macules, if you avoid any secondary depigmentation, that this also is also helpful. Same as hyperpigmentation, because both of them are usually secondary and are not going to allow for the identification of the underlying lesion. And for example, in this example here, if you see this in a patient, there is a skin problem, but it might obviously tell you that there is something more going on. So if you see any hemorrhagic lesions, it's really helpful to check for any coagulopathy as well. This is another example where a biopsy that's taken centrally is preferred. And again, because we're looking for vascular lesions underlying, a bit similar to the ulceration in this case, multiple samples are helpful, and deep wedges are really preferred if possible clinically. Okay, so we've covered all the skin biopsies, the possible skin changes in a bit of a nutshell here. I know it's a lot to process, but I want to keep a bit of time for questions as well at the end. So just so that you have the information as well. We have another exception to a general mass submission, which are whole digits. They can be amputated either because of a chronic inflammatory condition or because of masses. So they might be amputated because of that. The example that you see here on the right upper corner is the digit with the distal phalanx and the medial phalanx here, and the mass is here. And I hope you can appreciate that this particular mass doesn't go into the bone. It was a histiocytoma, but the dog was really bothered by it. You can see it's ulcerated on the top. So the decision was made to remove this mass, although in this case, it doesn't show any bone invasion. The thing to keep in mind with digits and other bony samples is that the report can take longer in these cases because obviously the bone needs to be decalcified to be able to cut into the bone and process a section. It's just something to bear in mind for the client as well. And then we have this specific case of symmetrical lupoic onychodystrophy, SLO, which for many, many years, the advice was if you can, then sacrifice a dew claw for the diagnosis, for the histological diagnosis. And this has changed a bit. So you can still consider amputation the dew claw or a P3 if necessary. But the clinical picture and the histology picture both waxes and wanes in these lesions. So in most of these cases, if you have brittle nails or nails that fall off on several paws, then I think the best thing to do is probably do a microbiology. You see if you have any chronic pyoderma type of lesion that's going on. But if that's either not there or if it's cleared and the patient still is losing all the keratins, losing all the nails, then it's very highly likely SLO. And the histology might not necessarily help you with that because we might be able to raise the concern, but it's always also clinical correlation anyway. So yeah, that's not the general advice is not anymore to just submit a QCLA. And I personally would probably consult with our internal medicine people before that, maybe show them a couple of pictures, clinical pictures, and discuss with them if a definitive diagnosis can be made without histology. And now we have a few other organs that I quickly want to discuss as well. Spleen, we see a lot of spleens, so a lot of spleens are submitted. I've been told by a human medical practitioner that this is not so often the case in human medicine, but in dogs and cats, especially dogs, we see a lot of spleens. And it's just something to keep in mind that any mass in the spleen, whether it's a hematoma, a stromosarcoma, just a nodular hyperplasia, really, any of these can look quite similar clinically. And I think this is also why we see a lot of spleens in histology, because clinically it's just not possible to distinguish these. I've already mentioned before the rule of the 6 samples. So ideally, spleen is one of the organs that we would like to see in total. We would like to see the whole spleen if possible, but if you don't have enough formalin, or you can't do this for whatever reason, then it's really helpful to sample a couple of areas of the spleen, I would say, and potentially a bit more even of the area that you are concerned about. Liver is again an example where the clinical information is really, really helpful. I've just given you 2 examples here. This is an example of a liver cirrhosis. This is an example of multiple abscesses in a rabbit. And it's really important to have the clinical information, such as ultrasound description, and also to mention whether it's a nodular change, a diffuse change, or more of a single mass. Because especially if you do a biopsy of one mass, for example, and there will be a lot of speculation, but if we don't know if it's a single mass or if it's a generalized change, it's hard to interpret this as well. And also for biopsies, it can be really difficult to distinguish malignant and benign lesions in the liver, because what we look at is the invasive behavior into the periphery, which we cannot really assess in biopsies. We can do endoscopic or full thickness biopsies of the gastrointestinal tract, and both have advantages and disadvantages. So I've put these tables here just so that you are aware of the limitations of either, really. So endoscopic biopsies obviously are less invasive, but they don't go as deep as a full thickness biopsy. Some lesions, for example, lesions in the jejunum, might be in an area that you can't reach with an endoscope. And I would say they are maybe slightly more prone to artifacts, but that really comes down to how you handle the biopsy after you've sampled, and that's the same for full thickness biopsies as well. The disadvantages of full thickness biopsies is it's a more invasive procedure, it's potentially more expensive for the client, and it's a higher risk of complications, and you can't really look inside the intestine, obviously, what you can do with an endoscope. So we will get some reports back where we give a diagnosis of an endoscopic or based on endoscopic biopsies, but we might still recommend doing full thickness biopsies later in the disease process if there is no resolution. The one thing that I would like to mention, because it does happen from time to time, if you do an XLab and you want to take full thickness biopsies, or you do an XLab, then the one thing that I would advise against is just to submit one biopsy of the mesenteric lymph node. As I said, I'm not a clinician. I know you can have complications as well with surgery. I'm aware of that. But I think once you see the abdominal cavity in front of you and you have a suspicion for a gastrointestinal disease, it really does make sense to sample some areas of the gastrointestinal tract as well. Because if we just have unless there is a very, very obvious neoplasia, for example, but if we just have a mesenteric lymph node biopsy, you will probably get this back as a reactive lymphoid hyperplasia, but this is to be expected in basically any gastrointestinal disease anyway. The oral cavity is another example where the correlation with the clinical picture is really, really important. We also would like to know the exact location. So if you just say oral cavity, that's good. But if you say gingival mucosa or lingual or whatever, fauces, that's obviously much better. And there are definitely a lot of cases where we encourage you to do diagnostic imaging to better assess the invasiveness of a mass, because especially in the oral cavity, you might be aware of the so-called histologically low-grade, clinically high-grade fibrosarcoma in Labrador retrievers and golden retrievers, some other breeds as well. They histologically can look completely bland. They can look like reactive tissue, but clinically they are very aggressive and very, very invasive. And really the distinction is just possible with diagnostic imaging. So again, these are cases where it's really helpful to just get in touch with us. If you submit a biopsy and you're really concerned about a really aggressive clinical lesion, and then it comes back with reactive tissue, and it just doesn't match what you're thinking, that is really helpful to just give us a call and say, look, the histology results don't really match with what my concern is. Can you have another look? Can we discuss? That's really helpful. Yeah, I've mentioned lymph node biopsies in general. Just something to bear in mind that subclassification of lymphomas is usually not possible just based on the routine listing section. So this is something where we usually require immunohistochemistry as an ancillary test. That's just something to keep in mind. And again, I'm aware it's not always possible, but if possible, if you submit a whole lymph node, that is preferred over lymph node biopsies. These are lymph node biopsies here. And I hope you can appreciate that they are a bit fragmented. And I think it's quite hard to say what is the architecture. And also something else to keep in mind, for example, especially in lymphoma, is that the surrounding lymphoid tissue, the tissue that surrounds the neoplastic cells, can be really reactive as well. So if we have a relatively shallow biopsy, we might just see the reactive tissue, but the lymphoma might actually be more towards the center of the lymph node. And this is a sample of a whole lymph node, which actually was affected by lymphoma. And you can see the architecture is better to assess in these sections. Nasal cavity can be really tricky clinically. That's something we know. So it's quite hard to avoid crush samples because of the bone in the nasal cavity, because of the turbinate bone. Again, it's very helpful to have the clinical history, including any imaging studies. Or if you suspect a mass, then it's helpful to tell us you suspect a mass and not just a rhinitis. And if possible, if a mass is present, it's really helpful to have samples from different areas, again, because there's a lot of secondary inflammation, a lot of mechanical irritation in this area, and it helps to just avoid that we just look at the secondary changes. The pathologist, again, says ideally really deep biopsies if you can do that clinically. And this is, again, like skin samples, it's a case where I think, yeah, it just makes sense to have some first samples for culture at the same time. And then you have these quite common lesions of depigmentation and crusting and ulceration around the mucocutaneous junction, the nasoplanum. And always the clinical concern, obviously, is any immune-mediated disease, for example, lupus. And again, that needs to be correlated with any previous treatment or any culture insensitivity, because the findings in lupus and the findings in chronic mucocutaneous pyoderma can be really similar histologically, so the distinction might be really difficult. And ideally, one of these cases where previous treatment and then sampling of it might be really helpful. And just quickly touching on the reproductive tract, I just had the case today actually where I had inguinal testicles. Well, only one was submitted, but the dog had 2 inguinal testicles, but only one was submitted. It was really helpful to have both, and that's for 2 reasons, because it's not so uncommon for especially dogs to have neoplasia in both testicles, and it might not be the same neoplasia. And at the same time, something to bear in mind is that the smaller testicle may be the abnormal one. The first thing that always comes to mind is that the larger testicle has a neoplasia, but the smaller testicle might actually be the one that is the abnormal one. So it's really helpful to have both. Prostate is it's not a sample that we get very often. It's very important to correlate this with the ultrasonographic appearance, especially if your differentials are hyperplasia or carcinoma. Especially the mineralized foci that you see on the ultrasound are concerning for carcinoma, especially in castrated dogs. So that's just something to consider as well. And in small biopsies, it might actually be difficult for us to give you a definitive answer. So that's, again, one case where we're looking at all the aspects and the clinical impressions as well. The ovaries and the uterus, again, is very helpful to have it all if you're doing an ovarian hysterectomy, to submit the ovaries and the uterus as a whole sample, if that's possible, or if you have to cut them, if you have to divide them, then at least submit both ovaries and the uterus, because obviously there is a lot of hormonal interaction there, and it's really helpful to be able to look at the ovaries as well. And I have a good example here of a long memory strip that I wanted to show you. So this is basically what we do in the lab. When we get a complete memory strip, we palpate all of them, or I shouldn't say we. So our lovely lab technicians, they palpate the whole sample, and then they give us a lot of slices of each and every area that looks or feels slightly suspicious for masses. If you have to cut them, let's say you have a long memory strip, you want to cut it in the middle, that's fine. It's just really important to say which one is caudal, which one is cranial, especially if you're not including the most caudal gland, which has all the adipose tissues. If you just say, you just submit a sample that's like this, then it's really helpful to say which one is caudal and which one is cranial for the margin assessment. And it does happen that you might think there are 3 masses, and then the report comes back with 5, and that's just because exactly of this trimming method. So we do look at a lot of sections, and we might find the smallest masses histologically that you were not able to palpate clinically, which is normal. So just don't be too surprised if we find more samples. And I would say for a memory mass, the excisional samples are usually much more valuable than incisional to be able to assess the invasive behavior into the surrounding tissue as well. And I think that might be nearly my last slide about bone. Bone is another example where trauma or any other history is really important for the clinical, for the histological and clinical assessment. Radiographs as well. Are there areas of lysis or proliferation? Anything really that you think might be helpful to interpret it, these sections. If there's any joint involvement, for example. And it can be really difficult. I have this example here where these two, so D and E, for example, these 2 sections here, they were a neoplasia, they were osteosarcoma. But then if you look at F, this little square here, this is just reactive bone. So you can imagine that if you do a biopsy that's quite shallow from this area, we will see the reactive bone. And the problem is that a lot of neoplasias in the bone, they have secondary reactive bone proliferation. So there's often this combination between the 2. And that can be challenging to find the deeper neoplasia if we just have a small biopsy from, for example, this area here. Again, as I said before, especially if it's a large sample, the decalcification step might take a bit longer. So that's just something to keep in mind. You are not going to get the report for a large bone sample within 3 to 4 days. It will definitely be longer, up to 14 days. Sometimes even longer, but if it's longer, you will get a message from our lab support team that it might take a bit longer. And this is just a list of potential other tissues that you can submit, things like postmortem tissues, whole hearts, whole brains, thyroid, kidney, eyes, ears, lung. All of this, obviously, you can submit to us. We don't do any postmortems in our lab, but you can submit these large samples. I've not included them all because that would be too much for an hour. And as I said, I would like to answer your questions as well. But again, my advice is really don't hesitate to reach out to us. As I said, there's always a pathologist on call for general inquiries, and you can always reach the reporting pathologist if you have a report back, and just speak to us, give us any more clinical information, or just discuss the case. That is always much appreciated, and we can always be reached, and I'm very happy to talk about reports as well. Okay, ready for your questions.
That's great, Stephanie. Can you hear me okay?
Yes, I can hear you perfectly.
Good. That's fine. We just had a slight technical issue earlier on, but that's fine. No worries. Yeah, so thank you for that. There's a couple of questions here, so I'll kick off with those that are in the chat. First one, you mentioned earlier about in terms of biopsies, and I think you were talking about scrubbing or not scrubbing. So the questions come from there. Without scrubbing prior to biopsy, how do we minimize risk of infection in an open wound afterwards? Do we just then clean after we've biopsied?
That's again, it's more of a clinical question, really. But I would say if you have a small area that you want to biopsy, if you keep that small area pretty untouched with no scrubbing and no cleaning, I guess you could still clean the area around that. And then if you, as you say, if you disinfect and clean afterwards, then I would say that's probably most risk-free for these here.
Great, perfect. There's nothing more on the chat at the moment. I don't know whether everyone has got any other questions that they want to come off mute and be brave and ask, or whether they want to stick them in the chat. Oh, here we go. That was quick. They're obviously typing furiously behind the scenes. So from Vivian, are there any pros or cons to doing an anatomical pathologist degree as opposed to a clinical pathologist degree? Does anatomical pathology give you more freedom to work with exotic or wildlife species? That's a tremendous question. I've never had one of those of the grad program.
That's an incredible question. I think that really depends on the area that you work in general. I mean, I've worked at the university before I started with IDEX, and I was a postdoc at the university, and we had collaborations with the zoo, for example. So back in the day, I saw a lot of exotics, zoo animals, giraffes, and elephants, and all that. So I think maybe if you want to, if someone wants to consider a more like university, work, then I think you might see maybe more exotics. I think in a diagnostic setting like IDEX, I think it doesn't really matter, because we do, I mean, most of our patients are, pets house, in the house, let's say, for example, dogs and cats, rabbits, guinea pigs, and so on. We do see a hedgehog from time to time, or a frog, but that's not our main case submission, I would say. So in that regard, I think in a diagnostic setting, that's probably the same for clinical pathology and anatomic pathology, I would say. The one advantage that we do have as anatomic pathologists, I have to say, so I have the utmost admiration for the clinical pathologists, because they are making diagnosis just on basically detached cells that are swimming in some fluid, whereas we are obviously able to see the whole architecture, and that is a huge advantage. I can say this as an anatomic pathologist. But I've only done very few cytology samples when I was at the university, so I'm really not an expert on that. As I say, I admire this. It's much more challenging, I think, than being able to see the tissue architecture, in my opinion. But yeah, I think in terms of exotics, or interesting, or not every case is interesting, but in terms of interesting cases or exotic cases, I don't think it makes much difference.
Great stuff. There's nothing else coming through just as I'm looking here, Stephanie. So what I might do, we're due to start our next session. Oh, hang on, spoke too quickly. Oh, that's just on the back of your answer, actually. So they're saying I'm interested in a broad scope of species, but excuse me, I want to be able to work in a clinical setting. So I'm trying to figure out which direction to take. So thank you for that. So that's great. No worries, Vivian. Right, what we'll do, our next session is due to start in... Oh, no, there's another question. There we are. I was going to give you 5 minutes, but you're all keen. So what would be the standard approach for submitting full organ samples?
The standard approach, let's say spleen, for example, or a whole lung lobe or a whole kidney. So the standard approach would be to submit it either in a very large pot, or to fix it in the practice